Lots of the discussion of what might happen if Medicaid's financing were to change is speculative, and what we're able to contribute is an actual observation on how public medical programs reacted in one other instance where their financing was capped. And so to the extent that the disagreement in the debate is about whether changing financing will make programs more efficient versus smaller, our historical experience pretty strongly suggests that it would make them smaller. Medicaid is financed now by what's called an open-ended federal-state arrangement, which means states that run Medicaid programs incur costs, and the federal government agrees to share those costs at a predetermined rate. This is designed so that lower-income states get larger subsidies from the federal government, and the point of that part of the regulation is to ensure that those states can provide a reasonable amount of care for their populations, where the idea being their populations may have greater need for Medicaid, and the states themselves may have less ability to raise the funds on their own to pay for such a program. Proposals to change Medicaid's financing have been to turn it into a block grant program, which means instead of sharing the costs of Medicaid between the federal and the state governments, the federal government would just give a fixed amount of money to every state. The proposal that we discuss in this paper is in between those two things. It's called a per capita cap, and it basically means that the federal government would continue to share Medicaid costs at a certain rate, but when a state's average Medicaid costs exceeded a threshold, the federal government would stop paying. What we show in our paper is that when we tried this proposal in the late 1950s and the early 1960s, in fact, the way that states responded to caps on their financing was not to somehow become especially more efficient. It was to restrict the types of people that could get medical care and the types of medical care that they could get. And so if these proposed policies will have a similar impact to what happened the previous time that we've tried such a policy, it suggests that in fact this will shrink the Medicaid program. Currently, there's no limit on states' flexibility if they want to be more generous. There are only limits on states' flexibility if they want to be less generous. So when these proposals talk about granting states flexibility, that almost only means allowing them to do things that would shrink their programs. That means things like establishing wait lists for new entrants, shifting patients to sort of subsidies to obtain private plans, limiting the number of services that were included in a given Medicaid package. So these are all things that states often cannot do now that they would be allowed to do if a per capita cap proposal were enacted. Most Medicaid recipients are poor children, and they don't spend very much. So some parts of Medicaid look very expensive, some parts look cheap. So the comparison between the average Medicaid patient and the average private insurance patient is not really an apples to apples comparison. However, in the paper we focus on changes in the cost per patient. And what we find is that while the cost per Medicaid recipient changed to some extent after Medicaid was put in place and instituted an open-ended financing system, what we also show using a different sort of set of historical data is that the costs per private insurance recipient grew even more during that time.